So while I'm getting this, it's great to see everyone, at least virtually. I'm usual annual visit and meeting everyone in person, but hopefully we'll meet soon. And I had logged in towards the end of the previous session, and obviously this is a great session. And congratulations, Umesh and all the organizers for this, creating this platform where the nephrology community, as well as the primary care, family practitioners, and as I understood, there are diabetologists were on the panel. So again, this is a wonderful opportunity to bring the community together to treat patients who require a multidisciplinary team approach, rather than we seeing them towards when the game is towards the end. And the only treatment options we have at that point is either talk about dialysis or transplantation. So my task today, as was assigned to me by Dr. Khanna, is to talk about chronic kidney disease, the early aspect. And again, I think it's never a duplication. People still use old terminologies, chronic renal insufficiency and chronic renal failure. And I think it's over 2 decades that the term chronic kidney disease was put in place and recognized by the entire professional community. I think we should get rid of these two terminologies, chronic renal insufficiency and chronic renal failure, and we should use the term chronic kidney disease. It is a major non-communicable disease, and it's been estimated that globally around 850 million people have CKD, and nearly 1 million die of CKD every year. So it is a huge problem. And as far as India and several developing countries, it remains clearly unknown because of lack of resources, lack of proper registry. We have extrapolation of data from smaller centers or regional centers, but clearly we do not know how big of a problem this is. And yes, the dialysis and the transplant options have improved significantly since the time, actually in the last 20-25 years. But again, without knowing how bad the problem is and how much more resources we'll be needing to manage patients with dialysis and transplant, I think that's not the path to take. The path to take is essentially identifying these patients early and trying to prevent or slow down the progression, and again, educate and build in health literacy so that people will be aware of taking care of their own health and the risk factors. Some of these early epidemiological outcome studies have led to, both from KDIGO as well as KDOKI, to come up with a newer classification that includes both not only the GFR, but also albumin urea. And I think this was discussed at great length in the previous session. But what I would like to highlight here is, now we have really recognized that not only GFR is important. So as the GFR keeps dropping, along with it, it's equally important to measure and ensure that there is whether there is any presence of proteinuria, or more specifically albumin urea. And this is where we lack. I think this is a common gap in implementation. We know from studies, we have guidelines where measuring albumin in the urine should be one of the commonly deployed tests, but in practice we don't do it. Recently, actually, we just did a survey at Cleveland Clinic, and only 40% of the patients had an albumin tested in patients who had an abnormal creatinine. The testing of albumin in the urine was relatively higher in the diabetic population, but even then, the estimation of albumin in the diabetic population was also in less than 50% range. So clearly, knowing one thing and implementing in clinical practice, there are huge barriers that we need to recognize, and each society and each healthcare system has its own set of issues that lead to not implementing these guidelines. And based on these, we really know that as the CKD disease progresses, yes, it becomes an irreversible path. Early on, there is a way to reduce the risk of CKD. There is a potential to screen CKD at a population level, and then treat and diagnose early and treat these comorbid conditions to slow the progression. I think that should be the goal here. But once the GFR starts declining, it's like a one-way street. There is no turning around. There is no U-turn here now. And then as the CKD progresses, we can slow down the progression to some extent, but eventually most patients will have either kidney failure or they die of complications of kidney failure. I am going to focus primarily on the early aspect of CKD, and I think Rajiva is going to focus on the later aspects of CKD. So who is at risk for CKD? And as partly was discussed earlier in the previous session, diabetes has become a major player for CKD risk. Globally, diabetes, almost 50% of our patients with chronic kidney disease have diabetes. The other common risk factors are hypertension, coronary artery disease, elderly patients. That's the largest growing population. Patients are getting old. Our overall health care has improved significantly, and patients get old, and as they get old, they develop some of these complications, which then ultimately leads to chronic kidney disease. And morbid obesity, as the socioeconomic structure improves, as the availability of fancy foods and luxuries improve, people have gained weight, and ultimately morbid obesity leads into higher incidence of diabetes, metabolic syndrome, hypertension, and coronary artery disease. So yes, ultimately everything boils down to hypertension, diabetes, and coronary artery disease as the three main risk factors for chronic kidney disease. And this has been very well shown in several studies that over the years, diabetes has taken over significantly compared to what we used to think glomerulonephritis, but that is now really not a major player towards chronic kidney disease. It's more of a major player towards acute kidney injury, which again, if not diagnosed in time, can progress to chronic kidney disease. So again, the message here is diabetes and hypertension, two major factors, which most often the patient presents with these two diagnostic dilemmas to the primary care physician, to the family practitioner. And that's where I think the treatment for chronic kidney disease should start. So chronic kidney disease is very much a primary care disease, I would say, rather than a disease of the nephrologists. And highlighting further on what was also talked about and what Dr. Khanna had mentioned, hypertension, diabetes, and CKD, hypertension, diabetes, and CVD, or chronic or cardiovascular disease. So the only difference here is K and V. And here, again, if we control these risk factors, if we can improve vascular disease, we can improve chronic kidney disease. Once the patient really progresses and starts progressing, so once they are on dialysis, as you can see, cardiovascular mortality becomes a huge challenge. The lower bar, the lines here are from the general population. On the top, it's the dialysis population. As you can see, in the general population, cardiovascular mortality increases with age amongst both male and female. And we've looked into different race, both blacks and whites, they have a higher incidence of cardiovascular mortality. But in the dialysis population, as you can see, even in the younger population, those who are 25 to 34 years old, the incidence, the annual mortality rate is several folds higher, and that stays higher and even gets higher as the patient gets older. So clearly there is some association between patients developing chronic kidney disease and patients developing cardiovascular disease. So the guidelines have really focused that I would be focusing on is in the early stages where it's imperative for us as a community, and by which I mean everyone involved with taking care of patients, and that's where I think the role of a primary care physician becomes very vital and crucial, where identifying the at-risk population will have the maximum impact on reducing the overall incidence of chronic kidney disease in the general population. So identifying risk factors early on in the disease, specific therapies to target these risk factors, and the risk factors targeting improving the cardiovascular disease as well as the treatment of cardiovascular disease. And then as the disease progresses, before it reaches stage 3, the slowing down the rate of loss of kidney function or slowing down the progression of kidney disease should become the major goal of therapy, which can then be handled in coordination and collaboration with the nephrology community. Stage 3, 4, and 5 essentially become, as I said, a one-way street, and Rajiva is going to focus on these aspects. Early on, I mean, one other aspect from a patient-centric perspective, if we look at it, again, on the x-axis is the GFR, on the y-axis is the proportion of population, and as you can see, these bars, they are the symptoms and the laboratory values, the chemical values that we do on a basic metabolic panel, they are abnormal. So as the GFR decreases, so as it gets from 90 to 15, that 15 is as close to where patients would generally get advised about transplant, about dialysis. The symptoms, the symptoms of difficulty in managing the physical activity goes down. The patients are unable to maintain their general activity. Their hypertension control becomes difficult. They become anemic, and their phosphorus and calcium level goes out of control. So yes, as the disease progresses, complications go up. So coming to what can be done in the primary care clinic, or when the patient is first being seen in the seeing his or her primary care physician. Yes, what tests are relevant, and how early symptoms can be confusing. So retaining fluids can be easily part of a kidney disease. It could be a part of liver disease. It could be a part of heart disease. So maybe as simple as the patient presenting with just edema. But again, one has to start thinking early enough about kidney problems along with the other organ damage. And 2 screening tests are basically what we need. We need a random urine sample and a blood test. A blood test to look for creatinine, and I think most labs are now reporting estimated GFR along with the creatinine. So a basic metabolic panel will give you the electrolytes, especially the potassium, creatinine, BU, and albumin, so you can assess the nutrition, and glucose, so you can assess the presence or absence of diabetes. And then a urine test, which is a random urine test. You want to look for microscopy to see if there are any red blood cells or any evidence of infection. But more importantly, urine albumin to creatinine ratio, which again helps identify early disease process. It's not just specific for diabetes. Any presence of protein in the urine, presence of albumin in the urine is a prognostic marker, where higher the amount of albumin, worse is the prognosis. And this is just a schematic presentation where the gray bar at the bottom is a GFR of 10, so that's essentially kidney failure requiring dialysis. On the y-axis is the GFR, and the schematic representation of how earlier intervention can impact delay in the GFR. So as early as you can get in the game, longer will be the patient's need for dialysis or transplantation, and lesser will be the complications, systemic complications related to chronic kidney disease. So key CKD management points, we have said it enough, and I cannot again re-emphasize diagnostic workup. And again, a basic workup with blood test and a urine test is where one should start. Managing risk factors, blood pressure control, blood glucose control, and healthy lifestyle, which also was touched upon in the previous session. And the key important thing that patients don't realize it, patients need to be educated upon, the role of medications, iatrogenic complications, role of alternate medications and alternate treatment pathways that patients often get into, where they hope and they believe that allopathic medications may be giving them more side effects, and they can go into alternate medications which are clearly not controlled either by FDA or any local regulatory, regional regulatory bodies, and are fraught with adulterants or unknown substances or toxic metals that can lead to further increasing the problems. Lifestyle modification, what I would highlight here is weight reduction. Clearly, if the patient is obese, quitting some tobacco in any form. Again, these are measures that we ask patients to do when we talk about cardiovascular disease. That's equally important for chronic kidney disease. And alcohol, as far as possible, avoiding alcohol. I think the social acceptance of alcohol, as I see it from the time that I left to now, has greatly increased in India, and alcohol consumption can again lead to poor control of blood pressure, indiscriminate eating and weight gain, increased cardiovascular disease. So avoiding alcohol as far as possible. But if one really enjoys social drinking, by definition is 2 beers per week or 2 ounces of any alcohol per week. Management of hypertension, I would just highlight the key points that I think would be relevant from primary care management perspective. That the goals of therapy, again, there are several guidelines that have come up, but ultimately one has to individualize. As far as possible, the target blood pressure goal should be less than 130/80 if the patient can tolerate. Having said that, if it's a younger patient, yes, one should absolutely try to get the blood pressure down to 130/80 or lower. If it's an older patient, elderly patients may have other comorbidities, and reducing the blood pressure low enough might lead to dizziness, increased incidence of fall, and that has to be weighed clinically. And one should try to accept a blood pressure closer to 140/80. Anything higher, unless the patient is really symptomatic from lower blood pressure, reducing the blood pressure, it has definitely shown to reduce the progression of chronic kidney disease. Use of ACE inhibitors or ARBs in diabetics has been also well described in patients who are non-diabetic with proteinuria. So again, using ACE or ARB is equally important as one of the antihypertensive agents, with close monitoring for creatinine and potassium. Ek chammach kam, I think Dr. Khanna has really pushed the concept of sodium intake in the general population. And yes, reducing the sodium intake is important. It helps with better control of blood pressure. And most of these patients with chronic kidney disease will require addition of diuretics. So early on in the CKD phase 1 and 2 or even 3, thiazide diuretics can be used, but later on, generally a loop diuretic is essential. Once the GFR is less than 30, the role of thiazide diuretic is not very prominent. We had a huge session a very successful session on diabetes and kidney disease. Again, I would highlight some of the important points. Hemoglobin A1C target less than 7% as far as possible. But I think more than 7% clearly has been shown to be detrimental for CKD progression. Again, it also depends on the symptomatology and other comorbidities and age of the patient. So lowering the target is important. Consistently lower target is more important. Newer oral hypoglycemic agents point I would raise here, and I did not attend the entire session, but I think metformin, which was an absolute no-no in the very recent past, if the GFR dropped below 60, that has changed. Metformin should be used, especially in patients who are obese. They have a higher incidence of insulin resistance. Metformin, along with SGLT2 inhibitors, clearly has shown to be a better drug, and up until GFR of 45 ml per minute with essentially some dose adjustments is important intervention for these patients. And again, this can be easily implemented in the primary care clinics. Intensifying insulin use with newer insulin pumps, in glucose monitoring tools, all of these, if they are available and if the patient can afford it, should be part of the therapy. I would like to spend a few minutes on avoiding nephrotoxic agents.
Tushar, we'll have less time for the session.
Oh, okay.
Okay.
So I mean, things that I would focus on is radio contrast agents, monitoring renal function when using ACE and ARB, and then adjusting dosages, especially things like medications like allopurinol and other antibiotics. Unregulated traditional medications clearly have shown to increase the incidence of CKD. Dose reduction and interval extension are the two major ways in which we can reduce the dose. Again, a commonly used drug in the primary care office setting is Bactrim or trimethoprim sulfamethoxazole. Again, these are drugs that can increase creatinine as well as cause acute kidney injury. So to summarize, increasing prevalence of CKD in the population is very well known, though we don't have the exact numbers. Early detection and prevention of progression should be the goal early in the disease process. And referring patients to a nephrologist, I should have written less than 45, not GFR of 30, but definitely less than 45. Patients should be referred to a nephrologist. Treatment of manifestations and complications, I think Rajiva will go into more details. And as the disease progresses, renal replacement therapy, referral for vascular access creation, education for transplant work possibilities and workup should be part of the intervention that both nephrologists and the primary care providers can help. I'm not going to go over the case. I think Rajiva has a good case that she discusses the entire timeline of chronic kidney disease progression. And at this point, I will end and thank you again for this opportunity and the privilege and honor and for the very kind welcome.
Thank you.